the cancer genetic. Tomorrow we will talk about multifactorial disorder and also genetics of hematopoietic disorder or blood disorder. So all of you are a medical doctor, yeah? Hopefully, no dentist, nothing? Okay. For all of you, maybe there will be a questioning. Who should do karyotyping? How long does it take? How much does it cost? And how is the indication for that? And which kind of equipment we need to do karyotyping? We will answer this question today and the next session. In the afternoon, we will go for multifactorial disorder. Hopefully, it will be informative. Hopefully, you will take a lot from this. And for tomorrow, I hope tonight you will have some reading, so the tomorrow session will be informative for you as well. Because without this, it would be a lot of information and maybe you would be confused. I am medical doctor from Tehran University of Medical Sciences, and I've done my PhD in Nottingham University in the UK, and I am the full professor in Tehran University of Medical Sciences. My face is young, but I am quite old. And I have 2 grandsons as well. So hopefully, 2 grandchildren. Last night there was a celebration for my nephew, and so confused for myself. Hopefully you will enjoy the session. Let's start. For us, all the trait and all the disorder would be in 3 classification. First of all, it would be chromosomal disorder. Today we'll talk about the chromosomal disorder. For example, someone is Down syndrome, someone is Turner syndrome. You see them in your clinic very easily, even you have seen them before as well. Loss or gain of chromosome is the result or the cause of the disorder. Maybe the problem is not a whole chromosome. Part of a chromosome would be deleted or amplified. Sometimes we have chromosomal translocation. One part of chromosome 1 will go to chromosome 3 or something like this with translocation. They are quite common, but there is not too much variation in them. At the maximum, there are about 600 disorders. So very easily you will understand them. When you see the patient, you can say, okay, it seems to be chromosomal. Let's go for karyotyping, and you will find out what's the cause of that. We will talk about this in these 2 sessions today. The second part will be single gene disorder. For example, some people, they say this is syndrome. Of course, some of the syndrome are single disorder, or Down syndrome is chromosomal. So the syndrome means when you have a complex of sign and symptom, doesn't matter, is it from Pakistan, from Iran, or from the Germany, it's the same. The single gene disorder would be problem of the coding region, which means the exons, loss or gain or alteration of protein function, or regulatory region. There is something wrong in the regulation, so the expression is not enough, decrease, increase, or inappropriate. They are quite rare. If it happens in a family, the risk of happening again is too much. Single gene disorder are rare. If it happens in a family, the risk would be as big as 50% if it's a autosomal dominant disorder. It will be 25% if it's autosomal recessive disorder. And it is common in the family, but it's not common in the general population. For example, in the 85 million population of Iran, we have about 20,000 thalassemia major, which is the same case for the Iraq, for the Pakistan, Afghanistan. In all regions, quite common. You will have the slide. Just the point I'm not. You can't see on the slide. You are hearing from my voice. You can write it down. Otherwise, you have it. The risk for everyone to have this single gene disease is 1%, 10 in 1,000. You are fine. Your couple or your husband, your wife is fine, but there is 1% risk for everyone to have a patient with single gene disorder for the first mutation, a de novo mutation. So nobody can say, I am fine, my wife is fine, so we are, hopefully the baby would be healthy. Nobody can say so. The third part would be multifactorial disorder. multifactorial disorder, tomorrow we will talk about this. It means the genes and environment, two together, is responsible for that. They are quite common. In your family, how many they have diabetes, how many they have obesity, how many they have hypertension, how many they have atherosclerosis, how many they have coronary heart disease. They are quite common. The risk of happening is quite high, and it is a reason by the genes and also environment, both of them. We say multifactorial, sometimes we name them as a polygenic. Tomorrow you will hear about this much more. But for the single gene disorder, my colleagues had lessons for you. So let's go for chromosomal abnormality. We will talk about karyotyping, how we nomenclature the chromosomes, and how numerical autosomal chromosomal abnormality happening. What is the consequence of that? Today we will talk about this now. Chromosomes are the chrome and zome. Chrome means they can be dyed, and zomes means body. Chromosomes, tightly coiled strand of DNA that form the human genome. By mistake, we say this gene is on this chromosome. It doesn't mean chromosome is a car and the genes is the passenger. This is not true. Chromosomes are tightly DNA, which means the genes are there. So that's a usual, by mistake, we say located on, or mapped on, or at that chromosome. Genes are chromosome, DNA are chromosome. When they are tightly compact, we name it as chromosome. Chromosomes are only seen during mitosis and meiosis. Otherwise, they are not vanished, but they are not compact to be seen by the microscope. In 1956, we realized it's about 46, the number of chromosomes. Before that, we said 48. If you see the books before 1956, it named the human chromosome 48. 44 of them are autosomal chromosome, 2 of them are sex chromosome. In next session, we will talk about sex chromosome abnormality, which is very interesting knowledge. Normally, if you have 2 X chromosome, it will be female. If it would be X and Y chromosome, it would be male. And of course, there are some problems in this regard. We'll talk about this next session. Why a physician should know about cytogenetics? Because it's quite common. 50% of spontaneous first trimester abortion is due to chromosomal abnormality. So when a lady comes to us and she said, I had 2 or 3 spontaneous abortion, we will ask them, please take care. We will study you and your husband, and please take care. If there would be abortion, give us the sample. We will do the karyotyping of the aborted product. For us, it would be a rule. For genetics, checking the patient is much easier than the parents. Checking the patient is much easier for anybody who are at risk. For example, somebody she said, I wanted to marry my cousin, and there is somebody in our family who are hearing loss. We say, can we have that patient who has hearing loss? Checking that patient is much easier than checking you to see if you have the same gene or not. So usually we ask them, please go and take the patient to come to us. So 50% of spontaneous first trimester abortion is due to chromosomal abnormality. When we say cytogenetics, means we study the chromosomes. Somebody say, I am a molecular geneticist, which means much more focus on the DNA. Somebody say, I am cytogeneticist, which means I am much more focused on the chromosomes. So the second high number on the medicine is 22% of pregnancy of women older than 35. It can be result in the cytogenetic disorder. Usually these days in all the countries, the age of the marriage is going to be up. The age of having baby would be up and up. This means the risk of the mother who is healthy, but for example 35, 38, 40 years, who wanted to have another baby or this first baby, there would be a risk for them to have a problem in the baby. We'll talk about this much more. 1% of all live births, mother fine, father fine for the first time, same number as the single gene disorder can happen. So it doesn't matter if mother and father are fine, it's not related to the consanguineous marriage. So cousin, the mother is more than 40 years, so the risk for the first time to have a Down syndrome is there. 1% for all live births. In the previous slide, I said 600 cytogenetic disorder. Here we say 100 cytogenetic disorder. Why this number is different from each other? Because some of the chromosomal problems are a little bit a small part of the chromosome. Some books name them as single gene disorder, some name them as cytogenetic disorder. So this 100 and 600 is due to that. But of course, they are quite common. Overall, much more common than Mendelian single gene disorder, but the number of variations with this disorder are not too much, and the risk of having again of that disorder is not too much. That's the difference between single gene disorder and chromosomal abnormality. So this is one of the important slides I have, and there would be question out of it. Indication. Indication means what is the time you prescribe for karyotype. When you ask, go for karyotype, that's the risk, or that's the list. Population at risk for chromosomal abnormality, when you ask for that. First, children with multiple congenital malformation. Hopefully, you will go to delivery room, the baby come out, and you see, oh, there is one finger much more than normal. There is cleft lip, and for example, there is club foot. 3 organs are involved: finger, mouth, and foot. Please ask, let's go for karyotyping. Why? Because 3 organs is involved. This means there is something wrong which is bigger than usual to result in the problem in 3 different organs. For example, you do delivery of the baby, and you see it is a small gestational age. Sorry, the weight of the baby is not too much. Usually it will be 3,000 to 3,500 kilograms. It's only 2,000. Sorry, gram, not kilogram. Yeah. I'm just checking, are you alive or you are dead? So 3,000 grams. Yeah. For example, the baby is 2,000 grams, and also you hear the heart, and you see the heart is not in the left. It's in the right. What is the name of that? When the heart is in the right side? Dextrocardy. So, a small weight, dextrocardy. For example, one kidney is missed. Or for example, there is cleft lip. There is some microcephaly is there. Because of these 3 organ involvement, you will do again for indicate for karyotyping. Also mental retardation. For example, the mother say, the voice of the baby is not fine, or he is crying too much, or he is not crying at all. So there is no urination, there is no defecation. These are all the kind of malformation. Growth and developmental failure, that's different. Anybody knows what is the growth and what is the development? When the mother suffers, we complain about the growth of the baby, and when the mother complain about the development of the baby. Anybody know? Growth.
Growth is after the birth and development.
Growth means measurable item. Height, weight, head circumference. These are growth. When the height of the baby is not too much, when the weight of the baby is not too much, when the baby is fine, but it's not growing very well, maybe it's decreasing or steady, that would be growth problem. Development means not, neck stiffness is not there, walking is not there, talking is not there, running is not there. It would be developmental problem, or maybe control of urination is not there. All of these would be development. That's the difference between growth and development. Any AD with growth or developmental delay plus malformation, 3 items, let's go for karyotyping. What about the others? Children with suspected chromosomal syndrome, I think the face is not fine. Maybe the ears are not in the same place, maybe down, or maybe this, or something, for example, this all would be some suspicion about the chromosomal abnormality, or maybe the face seems to be a Down syndrome patient. Let's go for karyotyping. Any suspicion? Let's go for karyotyping. 3, couple with multiple pregnancy loss. If a mother come and she said, I had 1 baby death, 1 abortion, and 1 baby come out after 1 week is dead, all of them will be pregnancy loss. Up to the age of 28 days, it would be neonatal death. The baby come out up to 28 days, death, it will be neonatal death. We will add together. 3 abortion, 1 abortion, 1 intrauterine fetal death, 1 neonatal death, it will be 3. Both should do karyotyping. Usually in our country we say, I am fine, you go for karyotyping. No, we both should do karyotyping if there is a kind of pregnancy loss. If mothers say, no, the first abortion I did it by myself, it won't be calculated. I did it, forget it. It was a spontaneous abortion, neonatal death, intrauterine fetal death. 3, let's go for karyotyping of both mother and father. Girl with short stature or primary amenorrhea, this is very important. Unfortunately, because of our culture, the lady are not talking about the menstruation period, the time of it, how long does it take, or you go for a drug to have menstruation period, that's a problem. Even I had a lady who was a secretary on the doctor clinics up to the age of 35. She went for the osteoporosis early. The doctor asked, are you have your regular menstruation period? She said no. The doctor said, you are short stature. You haven't checked for that? He said no. Then we realized it is a mosaic Turner syndrome. Up to the age of 35, she doesn't know. She is on the mosaic Turner syndrome. So the lady who are short stature, or there is primary amenorrhea. What is the primary and secondary? Anybody know? Primary and secondary amenorrhea? Amenorrhea means there is no menstruation period. What about primary and secondary?
Before birth, after birth.
Primary, it is genetically. Primary is genetically. For example, the lady doesn't have any ovary. The Turner syndrome patient, they don't have ovary, they don't have even the uterine. Uterine. That's because of my confusion from sleeping last night, sorry. Primary, from the first time it's not there. But maybe there is a lady who she is fine after some time due to tumor. It is a secondary amenorrhea, which means it was before but is not there. That's another issue. That's cancer. Let's check for the hormones. There is something wrong for the PCO, for example. But a lady with short stature or primary amenorrhea, we should check for that. And the suspicion is Turner syndrome. We will talk about this. It is very interesting today, next session. Male or female with infertility. Again, both should do karyotyping. A male and a lady who couples for more than 1 year, and they said 6 months without control, we don't have any pregnancy. It means infertility. Less than 1 year or less than 6 months without control, it doesn't mean. Maybe first is not working, second is not working, it takes time, they shouldn't be stressed, something like this, that's a different issue. But for the infertility, again for both male and female, because as I said, usually we say, I am fine, I am powerful, I am Hitler, you do the karyotyping. No, this is not the job. Another one, patient with ambiguous genitalia. This is very important. Again, you are in the delivery room, helping a baby come out. It seems to be male, but the penis is less than 2.5 centimeter. It would be ambiguous genitalia. Or maybe you see both of the external genitalia is there. It would be emergency, neonatal emergency. Because in the ambiguous genitalia, there is the danger of hypertension for the baby. There would be the risk of the tumor for the baby, Wilms tumor, when, for example, the testis would be in the abdomen. And also the risk of the electrolyte disorder is there. So usually we say, don't say he or she, say the baby, because we don't know, is it male or female? We should do karyotyping, we should check for everything, see is there any ovary there, is there any testis there, why there is ambiguous genitalia. It is very important. This baby should do karyotyping as well, plus the other examination which is needed. Also in some cancer, chronic myelodysplastic leukemia, usually, hopefully when you come to Tehran, you will go to Shariati Hospital. There is a hematopoietic research center. Usually a lot of patients with the leukemia will go there. All of them has a paper, go for karyotyping. Karyotyping is very important for them. And the last but not the least, as a part of prenatal testing, I don't know about your country. In some country we have this kind of screening, in some country we don't have. If the mother is pregnant and after 4 months she will come to us, we do a screening test for the health of the baby. If there would be positive screening test, again we go for amniocentesis and we do karyotyping of the baby. As a part of our testing, following positive screening result. Usually we take the blood of the mother, check the screening test. After that let's go for amniocentesis. We do checking of the baby for the karyotyping. These are 8 items of the karyotyping, very important. Surely there would be a question out of this slide. Let's go for numbers. I don't know, I don't want you to remember this number. This won't be the questioning about this, because maybe from Germany to Iraq to Iran to Pakistan, the number would be a little bit different. It's not an issue, but it will give you an overview of what's happening in the chromosomal abnormality. Chromosomal abnormality in the newborn, without any selection, unselected newborn, for all would be 10 out of 1,000, which is the same 1%. 1% of the baby you will help for the delivery of them, maybe they have a chromosomal abnormality. Of course, maybe, for example, in Iraq, because the age of the mother is going up, or in Iran, which is the same case, maybe it will be 2%, we don't know. We should check for that. Autosomal trisomy would be 1.4 per 1,000. Balanced autosomal rearrangement 5 per 1,000. Unbalanced autosomal abnormality 0.6. And sex chromosomal abnormality nearly 2 per 1,000, which is showing how the numbers are big. When you go, so the title would be changed. Previously it was in the newborn altogether, general population. Here we talk about abortion. When you go for karyotyping of the abortion, the number would be much, much higher. You see here, Turner syndrome, 23%, other sex aneuploidy 1%, autosomal trisomy 49%, triploid 13%, tetraploid 4%, rearrangement 0.3, unbalanced 3.1, and other would be 4.5%. So you can see Turner syndrome is quite high. Autosomal trisomy would be much, much higher as well. So let's go for, instead of trisomy together, let's go for division of them. Trisomy 21 per 1,000, it will be 1.5. Trisomy 18, 0.12. Trisomy 13, 0.07. Klinefelter, when there are a male with an extra X chromosome, it would be 1.5% per 1,000, sorry. Turner syndrome 0.4. Extra Y, there are two main problems. Extra X, extra Y, it will be 1.5 per thousand. The lady with triple X, it will be 0.65. In the next session, we will talk about sex chromosomal abnormality. When we check the chromosomal abnormality in spontaneous abortion or stillbirth, again, I'm telling you, if the number is changing from one slide to other, check the title, and also maybe based on difference, based on the country, based on the population of the country, maybe the number would be a little bit different from each other. All spontaneous abortion, 50% due to chromosomal abnormality. It was in the first slide as well. Up to 12 weeks, it will be 60%. 12 to 20 weeks, it will be 20%. Stillbirth, what will be 5%. What is the message of this slide? It says when the pregnancy goes on, the risk of chromosomal abnormality would be less. So usually when the lady comes to us and she said, I had 2 abortions, the question would be, in what age of pregnancy it was aborted? First trimester, much more chromosomal. Last trimester, much less chromosomal. It will be due to other items which we'll talk about them in this session. So this is very important. Usually we ask how many abortions you had. Was it spontaneous or you did it by yourself? Maybe mother doesn't want the baby and she aborted by themselves. This is not the abortion. It would be something else. It's not in the numbering of the health of the baby. And the question would be, on what age of pregnancy it happened? Again, in spontaneous abortion, trisomy 50%, Turner syndrome 18%, triploidy. Triploidy means 3N. We are 2N, we are 46. They would be 68. Yeah?
69?
Sorry, triploid. No. 23 out times 3. It would be 69. Yeah, 69. They are triploid. Translocation is 2 to 4%. So, human being has got 46 chromosomes, 22 autosomal chromosome, 2 chromosome X and Y. The DNA would be add together to be genes, and the genes all together would be chromosome. We have the short arm with the P and long arm with the Q. So we name them to see, doesn't matter is it from Pakistan, from India, from Iraq, from Iran, which part of the chromosome is the problem. We will find out the same address, which is very important for us, to give the same address. So usually we have 3 classifications: numerical abnormality, structural abnormality, and somatic mosaicism. Numerical means the number is not 46. We did the karyotype, we have 1 extra chromosome, it's 47. It would be numerical chromosomal abnormality. Sometimes the number is fine, it is 46. But there is something wrong, part of the chromosome is in another chromosome, we have translocation. It would be a structural abnormality. The third one would be somatic mosaicism. You will see about this tomorrow on cancer genetics. Somatic mosaicism means some of the cells has got something wrong, which is not the case in the others. For example, somebody is smoking, they have lung cancer. When you do karyotyping of the tumoral tissue, the karyotype is bizarre. Bizarre karyotyping. That's very important. Bizarre karyotyping means when you have a karyotyping more than 1 page, usually we have 1 page. You are fine, 46XXY. You are normal, 46XX, lady, male. But when you do a tissue of cancer, you do karyotyping, it will be more than 1 page, We say bizarre karyotyping. It says we have 3 chromosome 3, we have 1 chromosome 1, there are part of chromosome 9 on chromosome 6, on chromosome 8, on chromosome 16. A lot of page to report that. It would be somatic, so it means in some genes, on some tissues, not all, mosaicism. Mosaicism is something wrong in a part which is not in the other part. In the lung cancer, when you do karyotyping of the blood, it is normal. But when you do karyotyping of the tissue of the cancer in the lung, there is a 3-page report, something like that. So this is the 3 classification of chromosomal abnormality. So you see, from a very big issue, I'm coming down and down and on, much more focused on the cytogenetics. Excess numerical abnormality, it is amplification or there is deletion. Excess is extra. For example, Down syndrome, Mongolism, which is in the Lughat al-Arabi is the same, Mongolism. Any Arab, Down syndrome would be in Arabic language. Mongolism. Do you know what Mongolism?
Yeah, the Mongols.
Yeah, you have it. Mongolism. Down syndrome, trisomy 21. Patois syndrome, trisomy 13. Edwards syndrome, trisomy 18. These are the name of the people who describe the disorder for the first time. These days, there is no academic syndrome because there are confusion by the people. We have a kind of abbreviation or maybe which organ are involved. So these days, there is no name of the description by the person for the first time. Klinefelter would be extra chromosome on the sex chromosome. Deficiency. So duplication has a better prognosis. You should remember this name as well. Prognosis. Anybody knows what is the meaning of prognosis? Sorry? Say something. Doesn't matter if it's wrong or right.
Better
treatment.
treatment.
Prognosis means your information
Positive.
from the previous epidemiological study. For example, we say good prognosis or say poor prognosis. For example, somebody has a very complicated cancer, we say this patient will die in next month. It would be poor prognosis. Somebody has a very benign tumor, everything is fine, we say this tumor is good prognosis. Okay? We say deficiency has a much poor prognosis than the excess. The only alive chromosomal abnormality with deletion would be Turner syndrome. Other deletion of the chromosome result in the abortion, in the death of the baby. Deletion has a poor prognosis than excess or duplication. Only viable condition with whole chromosome missing is Turner syndrome. It is very interesting. In next session we will talk about this. All the lady are 46XX. One of the X would be inactivated. They are fine. Instead of this inactivation, the X chromosome would be deleted. The majority of this baby would be aborted. Some of them would be alive, but they would be on Turner syndrome. So, inactivation is physiologic. Deletion would be pathologic. So, aneuploidy, we are euploid, we are normal, we are diploid. Sorry, we are diploid, not euploid. Eukaryote is another issue. We are diploid, 2n46, alhamdulillah. Aneuploidy would be 2n plus minus 1. 2n plus minus 1, you will see that, which means 47 or 45. Polyploidy would be 3n or 4n, which means 69 or 23 times 4, 23 times 4. The trisomy 2n plus 1, monosomy would be 2n minus 1, and polyploidy would be 3 or 4 of homologous chromosome rather than 2. Why this happened? For example, we say complete mole. Complete mole. In Farsi, we name bache khore, means the baby was eaten by something. Bache khore means the bache is khorde shode, bache is eaten. Baby is eaten. Bache khore, complete mole. The mother is pregnant, everybody is happy, let's go for celebration. We do urine test, it is fine. We do blood test, it is fine. So there is pregnancy. But when we do sonography after some weeks, we say there is no baby at all. There is something on the uterine, but it's not a baby, it means mole. When you do karyotyping this mole, it will be diploid. Usually they are 46XX, and it is paternal origin. Both of the X's come from father, nothing from mother on the sex chromosomal part. It will be aborted, maybe spontaneous, or you do abortion under therapeutic abortion. So it will be complete mole. Sometimes we have partial hydatiform mole. Again, same clinic. The clinic is the same in these two. Pregnancy examination is fine, but you do sonography, there is no baby at all. In this one, it is triploid. Complete mole, 46XX. Triploid, it means 3N instead of 2N. It would be both paternal and maternal, both of them would be aborted. Usually arrays when an ovum without maternal chromosome is fertilized here in the complete mole by one sperm, which then duplicates its DNA, resulting in the 46XX karyotype, in which all the chromosomes are paternal derived, nothing from maternal ones. That will be a problem, and it results in the abortion. So when you have an abortion, ask the mother, can you check if you realize you are aborting the baby, put it on the normal saline and give it to us. We do karyotyping of the aborted part to realize what is the problem. Is it from the father? Is it from the mother? What shall we do in this regard, especially for the spontaneous abortion?
Sir, you said that in a complete mole, both X chromosomes is from paternal origin.
Yes. And the
male chromosome is only one X and one Y, then how two X chromosomes can come?
One, it says here, one of the DNA would be duplicated. So usually the sperm should be 1N, that's usual. But here we have something wrong. There is the sperm with 2N result on the pregnancy. That's a pathology. We don't know why this is happening, but it's happened sometimes.
Sir, what then happens inside the female body that leads to the eating of the baby? Or eating
No,
of the baby?
we say eating the baby. That's a kind of usual general population idea. There is no baby. It's some muscles or some tissue, but not something to eat something. But it's named as a bache khore, but there is no bache to be khore.
Sir, but where is the Y chromosome in this complete mole condition?
We don't know why this happened in this way. That's a very good question. Usually, a sperm is X or Y. Why? Because a 23 would be duplicated. That's 23 would be X, so there would be 2 times.
So sperm is XX in this condition.
That would be this one, 46XX here. In the complete mode. That's one another issue. The other abortion is another issue. When we have complete mode, the issue would be this one, because the sperm is 23, but it will be duplicated without known mechanism. We don't know why this happened.
So this is genetic defect of the parents, or it's during the embryonic development?
Embryonic development. That's the embryonic development problem, yes. You know, these days we say developmental genetics. Developmental genetics is a very young study. Why this happened in that specific family? How this goes up? It's very, very young issue. Developmental genetics, we are in the first lane of this. So the majority of answer is we don't know yet, unfortunately.
So screening of this complete mole is not possible?
Screening, yes, we do sonography, we realize there is no hand, there is no heart, there is no head. there is something wrong. So we will go for therapeutic abortion when we do karyotyping of that tissue.
Before pregnancy, we cannot.
No, before pregnancy, no, it's not
Okay.
possible. That's a very good question. He asked, can you do anything before pregnancy? We do something before pregnancy, but for this specific issue, we don't have any intervention for that specific one.
Sir, I think we have avoid even the sperm, we just have one, right? Like it has to be.
Usually the sperm should be one.
Half of the chromosomes, yeah, it should be.
That's the usual.
And half of the chromosomes with Y, right?
That's right.
So when the fertilization is happening, you are saying that DNA is duplicating.
In that specific issue.
It is duplicating.
Yes. Okay. Why this aneuploid is happening? You know, from 1956 till now, we know about the Down syndrome, but why this happened in that specific lady, we don't know yet. We don't know. La adrines for This is the hadith of Imam Ali. La adrines for Let's try to find it out, but up to now, we don't know why this happened in that specific man and women, not the other. But what we realize, something happened in the aneuploidy, because you know usually we have the meiosis to have 4 gametes out of it in the testis or in the ovary, doesn't matter. We have meiosis, meiosis 1 and meiosis 2, metaphase, non-disjunction, metaphase, anaphase. That's the cell division. You know about the cell division. The problem is non-disjunction. Usually we are normal, alhamdulillah, because we have disjunction. So disjunction would be physiologic, non-disjunction would be pathologic. That's the problem. Part of the chromosome should be divided to 2. Somehow this is not happening and we have non-disjunction. One of the reasons behind non-disjunction would be old lady. The lady more than the age of 35 are at risk for that. But why this not happening in all the old lady, we don't know. Somebody says, forget it, these are the nightmare of the doctor. They say so. My grandfather, grandmother had a very healthy baby. Alhamdulillah, that's fine. Yeah, they are fine. That's good. But 1 out of 30, 1 out of 40, 1 out of 50, depends on the age of mother, we have this non-disjunction. But why this specific lady, we don't know yet. Is there anything on the stress? Is there anything on the vitamin? Is there anything on that habit of that lady specific? We don't know yet. But the problem is non-disjunction. So usually we should have 1 S and a sperm or gamete. But on that specific lady or man, we have n plus 1, n plus 1, n plus minus 1, and minus 1.
Sir, if during embryogenesis, if during screening test, if we found the defective chromosome, can we fix at that time, sir?
That's a very, very good question. Okay, you realize that lady is old. Can you check, please, that ovum? Forget it. Let's go for that other ovum. It's not possible. No. Any manipulation on the sperm or on the ovum is very difficult because we are talking about only 23 chromosomes. Very, very small one, and the development is very specific. Even nowadays, we can say even the baby out of IVF, maybe they would be at risk for some multifactorial disorder at the end. But up to now, it's not very clear. Is it usual or not? So some people who are against on this kind of manipulation, because we have it in some religion or some country, they say, don't do anything. Why you do IVF? Why you go for, I don't know, cloning? Why you are going for surrogate motherhood? These are if I hear on a meeting they say this is the evil vow. He said, وَلَنُغَيِّرَنَّ خَلْقَ اللَّهِ. So this kind of manipulation would be the act of the evil. We say, no, please. We are talking about a family. They wanted to have a baby. They use a kind of stress, there is a lot of complaint, they have to put a lot of money in this regard. So this is not an easy answer questioning, but the question is, can you do anything on the screening? We have some intervention, we'll talk about this, but it's not too much. We can do something, but not too much. For example, somebody says, okay, can you, for example, if you do a screening of the baby and you realize the baby has got a heart defect. In some heart defect we have surgery even in the abdomen of the mother. But for example, you're asking me, okay, you realize that this baby has only one kidney. Can you do implementing another kidney or you do transplantation? There are some paper as a kind of research, but not as a usual practice of the medicine. You had a question?
Yeah, like not even by genetic editing we can.
Genetic editing, that's the answer would be for the future, but not now. Genetic editing, CRISPR, these are very new job we do, genetic editing. But I will answer. Remember, if you didn't answer, I forgot to answer, please ask me, but I put it here to talk about this. Genetic editing is an answer, but not an easy job.
So,
Any other?
with this non-disjunction, how does the meiosis II happen?
How
How the meiosis II happen here?
Yeah, the meiosis goes on because there is no kind of proofreading. When this non-disjunction happens, it results on Turner syndrome, it results on the Down syndrome. Or maybe result in the abortion. Maybe it results in the abortion because the majority of Turner syndrome will be aborted. You will see in the next session today. But maybe it results on the abortion or maybe it results on the having a live birth baby with a lot of complication.
So, can you explain the physiological condition of disjunction, non-disjunction in anaphase 1? What is the actual process?
Usually, as we said, we have part of the chromosome from the father, part of the chromosome from mother. When they act together, it would do mitosis. When we have the first cell. But these are talking about the spermatogenesis or oogenesis. Usually we are 23 and we wanted to have 4 gametes out of one sperm or the ovum. Usually we have 4 out of it as a usual, and usually one chromosome 1 divided to 2. So they should be divided from each other. This will be the disjunction as a usual. Here something wrong between the 22 chromosome, one of them will be non-disjunction. That's the usual way of the spermatogenesis or oogenesis. In the next session we will add this to this information. Just give me some time and be patient. The aneuploidy would be numerical chromosomal abnormality, monosomy, trisomy. Aneuploidy is generally caused by chromosome non-disjunction. That's the important issue. Aneuploidy is generally caused by chromosome non-disjunction, as usual. This is another interesting information. What is the percentage of mistake in different part of the human being age or time? The spermatogenesis has 1 to 2% incidence to have chromosomal abnormality. It will be 10 times much more in the lady than the male. For the male, it would be 1 to 2%, in the lady, 20%. So the maternal age, advanced maternal age is an issue here. But for advanced paternal age is not a big issue. So this means the proofreading system in male is working much better than the ladies. And the important issue is lady in each menstruation has only 1 ovum, but the male has got 1 billion sperm. So the number is very, very different from each other. So when you have 1, that will be a lot of mistake on that one. When you have 1 million or 1 billion, so this is not a big issue. So usually the best sperm visit the ovum. Then we have sperm and oocyte together. The pre-implantation embryo. When the embryo is developed, we have pre-implantation before implanting in the uterine of the mother. The risk will be 20%. This means maybe the sperm is fine, the ovum is fine, but in the implantation there is something wrong, or the mutation happened here for the first time. So sperm is fine, ovum is fine, the mitosis is started with something wrong. Then we have prenatal abortion, the number is not clear. Spontaneous abortion up to 50%, but here it's 35%. Usually there would be Turner syndrome, trisomy 16, trisomy 21, trisomy 22. These two is coming for the first time. Usually you hear about Turner syndrome and Down syndrome. So in the spontaneous abortion, when you do checking of the aborted baby, you can say trisomy 16. Because we say, why we don't have trisomy 1? Where is the trisomy 2? Is there a trisomy 3? All this trisomy can be seen in the abortion, but not in the alive baby. So in the stillbirth, which means in the end of the pregnancy, stillbirth means the death of the baby. In the end of the pregnancy, it will be only 4%. Instead of 35, it will be 4%. When the age of the pregnancy grows and grows, the risk of coronavirus will be much, much less. Here it will be trisomy 13, 18, and 21. In the live birth, it will be 0.3, and these are the usual common chromosomal abnormality. This is another important slide. See? Okay, you said trisomy 21, trisomy 13, trisomy 18. How much is the percentage of the abortion? How much is the percentage of the alive baby? For the Down syndrome, only 25% of them survive to birth, which means 75% of the Down syndrome patient will be aborted. So we can see it on the aborted baby. When you karyotype that aborted baby, for trisomy 13, Patois syndrome, it will be 2.5%, which means that 97.5% would be aborted, only 2.5% would be alive. For trisomy 18, only 5%, 95% of would be abortion. So this is very important rule. Fetal loss rate is high for all aneuploidy. The majority of aneuploidy result in the abortion. So when a mother comes with 2 or 3 abortions, we ask them both. You should go for karyotyping. So this number is very important. It's the same in the different population, usually. Okay. The baby is coming out. You realize there is cleft lip, there is cleft palate, there is deformity of ears, there is some extra finger, which means it seems to be a kind of aneuploidy. Let's go for karyotyping. We do karyotyping, we realize, okay, this is trisomy 13, this is 13, trisomy 18. They're asking you, okay, what happened to that baby? Is she normal? Can I do some editing? Or can you ask to have extra chromosome vanished? The answer is this. Survival in the individual. Survival is another name for the prognosis. When we say prognosis, we only have poor or good, but it's not calculatable, measurable. In survival, we have measures. For the trisomy 18 and trisomy 13, high postnatal mortality. Neonatal, postnatal, perinatal. That's very important. After delivery, the majority of them are death, mortality. We have mortality and morbidity. Mortality is death, morbidity is some patient or disorder. Median survival time under the 1 week, 5% of them survive to more than 1 year. So, unfortunately, father, mother, this baby usually would be dead in 1 week. Maybe it goes to 1 year, but only 5% of them would be more than 1 year. The 95% would be died in the
First week.
first year of the life. So in Iran, we have a regulation by the leader Ayatollah Khamenei. It said if the baby is very complicated, there would be usra and haraj, which is an Arabic language, meaning, which means there is a lot of problem for the mother and father to have this baby before ensoulment, before 4 months of the baby. If you do diagnosis of that baby, you can go for therapeutic abortion. Therapeutic abortion of the baby who is very complicated, for example, trisomy 13, trisomy 18, because it would be died in the first week, and there would be a lot of stress for mother and father, and the health of the mother would be on danger. So we go for therapeutic abortion. That's different from spontaneous abortion. That's different from illegal abortion. Another issue. We usually do amniocentesis. First we do a screening, then we realize there is something wrong. We do diagnosis by amniocentesis. Then we ask them to go for legal medicine organization. In Farsi it would be پزشکی قانونی. Some countries say forensic medicine. The forensic medicine, they check the baby is complicated, there is something wrong, there is no ensoulment, it's more than 4 months of the baby, of the age of the baby, let's go for therapeutic abortion. I know in some countries we don't have this. For the trisomy 21, that's very different. So trisomy 18 and 13 is very same clinic. Only by karyotype you can realize is it trisomy 13 or trisomy 18. But trisomy 21 is very different, much higher survival. 85% of them survive to 1 year, 80% to 10 years, even 50% can expect to more than 50 years. Why is that? The Down syndrome patient usually die due to heart problem or due to lung problem. They have a lot of cold and a lot of viruses, and usually they died before. But usually these days, because we have very good antibiotic, we have a very good access to doctor, usually even more than age of 50, they are alive. So you can see in the meeting, in the street, some Down syndrome patients. The first question would be, how much was the age of the mother, of the pregnancy of the baby? Usually they are old to have this kind of babies out of it. We will talk about these trisomy 13 and 18 and 21. So, the Down syndrome account for 10% of all mental impairment in the USA. 10% of mental impairment patient on USA is due to Down syndrome, which is big number. The most common pattern of malformation in the human being. The most common malformation is Down syndrome. You have seen, all of you have seen some Down syndrome patient. For example, as a kind of case report, the father is 35, the mother is 33, the mother is pregnant. Based on the size, on the mother age, the risk for pregnancy with Down syndrome is 1 per 6 to 5. What does it mean? When 625 ladies are pregnant at the age of 33, one of them has got the risk to have a Down syndrome patient. This number is for every country. Every country has this kind of calculation. From the country to country may be different. That's different. For example, I was in a meeting in the Kuwait, and they said the Kuwait is much more higher than Emirates, Qatar, Bahrain, and Oman in the Persian Gulf area. The Kuwait has a higher number, and we don't know why. Much more in Kuwait, and what is the difference between Kuwait and Oman, Qatar or Iraq, we don't know. But this is the number. Based on the age, we have a risk calculation. 625 ladies, one of them has got the risk to have a Down syndrome patient. Then we go for a screening test, which is, it would be a kind of blood test. We do free beta HCG and alpha-fetoprotein. In the Down syndrome, free beta HCG would be higher, alpha-fetoprotein would be less. So the risk adjustment would be 1 per 170. So less than 1 per 250 would be positive. It would be positive. Less than that, more than 125 would be negative. When the screening test will be positive, we will go for amniocentesis, CVS sampling, or of course we do sonography to be sure there is only one baby, because otherwise the number should be changed, and be sure the baby is healthy. Let's go further. The baby is unhealthy, let's go for therapeutic abortion. That would be the karyotype of the baby. When you do amniocentesis by the guide of sonography, you will have part of the part of the water of the uterine. In there are some cells of the baby. You do karyotyping, you show that's the sample from the baby, not from the mother. You see all the chromosomes are fine. Here we have something wrong. 3 instead of 2, chromosome 21, and we don't have Y chromosome, so it is female. So it will be 47 XX lady plus 21. You see, all the chromosome is the same, but the copy number is changed. So we have some specific wording. Copy number change. Copy number change. We are fine. Alhamdulillah, 46. Here we have 47. 1 chromosome is extra. This means all the genes on the chromosome 1021 would be 3 copy instead of 2 normal copy. So it happened a lot of problem. It resulted in a lot of problem. So in about 95% of all patients with cotrisomy 21, it results from meiotic non-destruction of the chromosome 21. This extra chromosome is maybe from the father or maybe from the mother, but the usual one would be from the mother, because the mother is old enough. So that would be the result out of it. In the general population, forgetting about the age of mother, the risk is 1 in 800. So 800 delivery you are helping, one of them would be Down syndrome patient. What is the face or feature of the baby? The important one is hypotonia. When you see for the first time a Down syndrome baby, you cannot forget it. Because when you, for example, take the hand, it dropped. There is no tonicity, hypotonia. When you check the neck stiffness, there is no neck stiffness. The head goes very, very loose. Hypotonia is there. Round head and third fontanelle. We have 2 fontanelle in the baby. This one has got 3 fontanelle. Flat nasal bridge. There is no nasal bridge. Even you do sonography of the baby when the mother is pregnant, you see there is no nasal bone. When we don't see any nasal bone, it means maybe they are a Down syndrome patient. Open mouth. Usually the mouth is open, the tongue is quite big, protruding tongue. The eyes are distinct because they have epicanthal fold. The eyes are distinct because of the epicanthal fold. The hands often have a single palmar crease. I will show you. And there is a gap between the first and second toes. 40% of them has got congenital heart defect. That's the result of the death of the baby, because the congenital heart defect is there. Even maybe you have to do 3 surgery when the age of the baby is less than 1 year. Very, very small baby with a lot of heart defect, so you should have to do several cardiac surgery, unfortunately. So everybody now check their finger. Usually we have 2 normal palm crease. Here we have another Siamese increase. So it is one of the hallmark of the Down syndrome patient. It doesn't mean if you have it, you are Mongol. No, you are fine. The problem is 3% of the normal population has it. 2 to 3% of normal people has it. Down syndrome, 50% of them, which means 50% of Down syndrome patient does not have it. Alcohol and fetal alcohol syndrome. The mother who are heavy drinker, unfortunately, this semen increase can happen in the hand of the baby. So between hallmark and pathognomonic, there is difference. We say 40% of patient with Down syndrome has got heart defect, which means if there is no heart defect, doesn't mean there is no Down syndrome. 40% of them has it, 60% of them are not have them. So these two finger, 1 and 2, in the Down syndrome patient is very distinct from each other. There is a gap between them. Okay, that's another important issue. 95% of Down syndrome patients are full trisomy. 90%, all chromosome has got one extra chromosome 21, 95%. 4% they are Robertsonian translocation, which means the number of chromosomes are normal, but there are Robertsonian translocation, chromosome 13, 14, 15, 21, and 22. They have a kind of 13, 21, 14, 21, 15, 21, 22, 21. That's a kind of translocation happened in this group. 4%. This one is very important. If this happens in a family, it can happen again. So if somebody says we are a family, 2 of our baby are Down syndrome, we can say, okay, maybe that's this one. Robertsonian translocation is the result of happening it again. 1% of the patient has got mitotic non-disjunction. The meiosis is fine, sperm is fine, ovum is fine, but when we have the fetus, it is happening in the mitosis of the baby. So this would be mosaic. So this means not all the chromosome, but part of the chromosome has it. So if, for example, 2 Down syndrome patients come inside of the clinic, one of them is very noisy, very complicated, very unclean, other one is say salam, how are you, and is much better. I can say the second one is a mosaic Down syndrome. This means much more educational, much more healthier, because part of his chromosome, part of the cell are trisomy 21, not all of them. So please remember this number, it's very important. 95% full trisomy, they are usual. That's the usual way. This 4%, there is very high risk to happen again. So when we see this kind of Robertsonian translocation, we check the father and mother to see is there a problem in the sperm or in the ovum. So they shouldn't do a screening, they should go for amniocentesis all the time, because there is high risk to happen again. The third one, you say mother, father, this one is a very better baby rather than the other usual Down syndrome, because some of the cells has it, others are fine. Usually, I will show you how we report the mosaicism. So, the mosaicism, these individuals are less affected, much better informative, much more better educated. Even I saw some patient in the Kuwait, he can get the driving license because it's much more educatable, so he can go for this one. It means it has the mosaicism. In developmental prognosis, this is a very hard questioning answering. Okay, unfortunately the baby is Down syndrome. What will happen then? You say up to age of 50% of them will be alive. What can we do for this baby? During first year, mild delay in early social and emotional development. Maybe mothers say the talking are much later than the other baby I saw before. Language and motor delay more apparent in the second year. Developmental milestones are usually, but not always, delayed. Late talking, late walking, late control of urination is a Down syndrome patient. Usually the IQ is between the age of 20 and 85. The IQ would be between 20 and 85. You as a doctor, your IQ is more than 100. But here it has between 20 to 85, which means 85 nearly normal. That would be mosaicism. But 20 would be full trisomy. Roughly, Down syndrome children attain overall learning ability of 6 to 8 years age. You can say this baby, if you go for all the kind of teamwork education, going to different doctor, physiotherapy, everything, the IQ of that baby, the amount of education for that baby is the same as a baby with 6 to 8 years age.
Doctor, can we get a break?
Yeah, wait. Down syndrome. After that, yeah. So that's the calculation based on the age of the mother. Between the country, it will be a little different. For the mother of the age of 20, 1 in 1,500, 30, 1 in 900, 35, 1 in 400, 40, 1 in 100, 45, 1 in 30. This means mother with the age of 45, 29 of them, the baby would be healthy, one would be Down syndrome. This means it is only a risk by the chance. You can't say, I am poor, I am mu'min, I am kafir, I am poor, I am rich, doesn't matter. 1 out of 30 at the age of 45 of the mother would be at risk. Usually after the age of 35 in Iran, we don't do a screening. We go for amniocentesis directly. Mother, you are more than age of 35, you are at risk to have a aneuploidy patient. Forget about a screening test. Let's go for amniocentesis after the age of 35. Before the age of 35, let's go for a screening. The question is, okay, you say after the age of 35 it will be high risk. Why shall we do a screening for the age of 20, 25, 30? Because the majority of the pregnancy is at that age. Of course the risk is low, but the risk is not zero. So we do a screening for that ladies. The screening should be there because there will be a lot of problem when the trisomy 13, 18 or 21 will be the case. Maybe result in divorce, maybe the result in suicide, we don't know. A stressful human being is there. You have a question?
So you said after 35 years we do amniocentesis.
Directly, without
What is
screening.
amniocentesis?
Amniocentesis, I said, by the guide of sonography, we take some water of the ovum of the mother, uterine of the mother, between ovum and uterine insect. We take the water from the uterine of the mother. In that water of the uterine of the amniotic fluid, there are some cells of the baby. So we do carotiding of that cells and we result if the baby is healthy or not healthy. Sometimes instead of amniocentesis, we do CVS sampling. We take sampling of the choriovolus of the baby for the molecular study. But for the amniocentesis, we take the cytogenetic study. Okay. All the time we say mother, mother, mother. Are you against the ladies? No, that's the medicine. But it's not true all the time, mother. 5 to 10% of Down syndrome is the result of paternal origin. You can check this 21 extra, is it from the father or is it from the mother? 5 to 10% is not maternal, it is paternal. Usually maternal vertebral destruction is the case, but in 5 to 10%, no, the problem is in the paternal origin. Okay, you can go for a break or after 5 minutes.